begin. Hi everyone, thank you so much for coming. My name is Amy Sam. I am the Health Education Project Specialist here at the Maxwell and Eleanor Blum Patients Family Learning Center. I help coordinate all the programming here. Before we begin, please be aware that Mass General will be live streaming and recording this presentation for Mass General social media. Mass General staff are trained in patient safety and privacy. The staff will not interfere with the presentation in any way. If you're not comfortable asking your question out loud, you're welcome to place your question on the card. Simply raise your hand and I'll come by and I can ask a question for you. So today we have Dr. Doreen DeFaria. She is the Associate Director of the MGH Adult Congenital Heart Disease Program, the Co-Director of the MGH Cardiovascular Disease and Pregnancy Program, and the Program Director of the Cardiovascular Disease Fellowship. She is here to give a talk on adult congenital heart disease today, so please join me in welcoming Dr. DeFaria.
Okay, thank you so much for inviting me here today. Again, my name is Doreen DeFaria. I'm a cardiologist here at Mass General. I actually did my training here at Mass General a number of years ago and have been on staff here taking care of congenital heart patients for the past decade or so. I see primarily patients in the office who are born with heart defects, with congenital heart disease. I see them as adult patients when they may have some complications that may arise as a result of some of their early childhood surgeries. We're here to talk a little bit about the congenital heart disease population, how critically important it is to educate ourselves and our medical community about congenital heart disease, as many things have changed and evolved over the last 5 decades. I will say that today this webinar is brought to us with the very generous support of our patient and our patient's family. Lori Ankerud and Eric Ankerud have been patients here in the adult congenital heart disease practice for quite a long time. I won't say how long, but Lori, I think, is someone who has embraced her heart disease and has taken such extraordinary care of herself and really thrived to be someone who has enjoyed life with a very healthy heart because of her dedication to the care of her heart. Lori and Eric are the founders of Heartfelt Dreams Foundation, which is a foundation that aims to help support the betterment of congenital heart disease patients. It's aimed to help encourage education for not only patients, for their families, but also for the medical community, doctors and nurses who may not interface with congenital heart disease patients often. They also aim to help and support the emotional, financial support for these patients to obtain access to advanced specialized care for their congenital heart disease to really have the best possible outcomes. So thank you so much to Lori and Eric for sponsoring this webinar today, and to Heartfelt Dreams Foundation. So we'll spend a little bit of time today talking about what congenital heart disease is. We'll touch very briefly on the different types of congenital heart conditions we may encounter. We'll talk a little bit about how the demographics has changed quite significantly over the past several decades. We'll talk a little bit about where there are gaps in our knowledge about how to best take care of patients with congenital heart disease. And we'll also talk about why it's so important for patients with congenital heart disease to be seen by doctors and nurses who really have an expertise in that area. We'll talk also a little bit about how acquired heart disease, coronary artery disease, cholesterol blockage, and arrhythmias may impact patients who are born with congenital heart disease. And then very lastly, we'll talk a little bit about pregnancy and why the risks of pregnancy are a bit higher for women who are born with congenital heart conditions. So what is congenital heart disease? Well, any condition that results in an abnormality of heart development is a congenital heart defect. And interestingly, congenital heart disease can come in a huge variety of flavors, from a very simple abnormality, maybe a small hole in the heart where the rest of the heart is entirely normal, to a very complex and very severe variant of congenital heart disease where there may only be one pumping chamber rather than 4 separate chambers. These are very different types of congenital heart defects, and as a result, they require very different types of long-term care, different types of surgical treatment, and they have different complications moving forward later in life. Here we have just a small little example of what a normal heart looks like. So normally the heart will have 4 chambers. You have 2 chambers on the right side of the heart that receive blood after the body has extracted all of that oxygen out. So we call this blue blood. It actually, when you physically look at it in a tube, is darker than normal. That blood comes in without oxygen to the right atrium, the right ventricle, and then it gets pumped out of the pulmonary artery. The lungs will then provide oxygen to the blood, and that red blood, filled with oxygen, gets returned back to the left heart, the left atrium, left ventricle, and that left ventricle will pump that blood out the aorta to the rest of the body, to the brain, to the arms, to the legs, to the kidneys, with lots of oxygen, so all of those organs can extract out that oxygen. It then becomes blue blood again and comes right back to the heart. So that's the normal circulation. Anything other than that is abnormal and would be considered a congenital heart defect if that abnormality occurs during the development of a fetus while the baby's in utero in mom's belly. So here's an example where this heart didn't develop normally, and there's a large hole in the middle of the heart. As a result, we see mixing back and forth of that blue blood and that red blood. So we end up getting mixed blood that has a lower oxygen content leaving the aorta. These babies often are born blue in that they can't get as much oxygen to their body because of this severe defect. This type of problem requires a pretty complicated surgical intervention very early in life. This is an example of another defect called tetralogy of Fallot, one of the more common congenital heart defects that we see in our clinic. This is a constellation of 4 abnormalities of the heart that ultimately also leave the blood being a bit less saturated with oxygen in the newborn baby. So there is a hole in the heart called a ventricular septal defect. This aorta sits and overrides over that ventricular septal defect. There is blockage of the pulmonic valve or pulmonary stenosis. And as a result of that pulmonary stenosis, this right ventricle gets very thick because the pressure in that ventricle is very high. Years ago, it used to be that we may not have picked up this diagnosis until children went to school and they started running around and they were noticing they didn't feel good or they may squat down. That's the body's way of trying to compensate and bring that oxygen level up a bit. Now these both are diagnoses that we can make in utero, in that when the mom is pregnant, we can do an ultrasound, look very carefully at the heart and pick up these defects, and we'll know that this baby is born with a congenital heart problem and offer that baby surgery very early in childhood, such that they have the best chance of having that heart develop more normally over time. So the vast majority of congenital heart defects, when they're diagnosed in childhood, they're picked up and they can be repaired in childhood. But often, importantly, these patients may need other interventions later in life. For example, among patients with tetralogy of Fallot, we can patch up that hole and open that blocked valve. But very commonly later in life, those patients may develop a very leaky valve, and then when they're, but it's not cured. It requires lifelong follow-up, and it requires careful monitoring of some of these complications that can develop later. Interestingly, sometimes we make a diagnosis of congenital heart disease in people later in life. They weren't aware that they had a congenital heart problem, and then we may pick it up when it starts to cause problems or symptoms later in life. And I remember one of the first patients I saw here after I finished my training was a 72-year-old patient who came in with a new arrhythmia, and lo and behold, when we reviewed his echocardiogram, he was actually born with a pretty sizable hole in his heart that hadn't really caused him any problems until this point in life. So that's a little bit unusual, but it certainly happens. And when we talk with our fellows who are training in cardiology, training to be cardiologists, we always talk with them about the importance of knowing that sometimes we can make a diagnosis of congenital heart disease later in life, and to be thinking carefully about that. And most importantly, patients with congenital heart disease always need long-term follow-up. So this slide is actually a slide that was adapted from an original paper in 1964, where doctors and surgeons at that time looked at babies and children born with congenital heart disease, and they followed them over time to look at the overall survival or the timing of death. So to clarify this a little bit. We have percentage of death on this axis here, and we have age in years. So if you look at a normal adult without congenital heart disease, more than 50% live to be over the age of 70. That makes sense, right? Now the average age is even higher than that. This was done in the 1960s. But if you look at patients with various types of congenital heart defects, their average age of death was in the 30s if they did not have surgical repair. So this is what we call a natural history study. This sort of documents how people did before the era of cardiac surgery. And you can see for the vast majority of these problems, these patients would not really make it far into life because they would have complications of their congenital heart disease fairly early in life. There's some very severe variants of congenital heart disease where really very, very few of those babies made it out of the first year of life. And you'll see for our tetralogy Fallot patients, 50% of them made it to age 10 without surgery. So in the late 1950s, 1960s, early 1970s, when we started having the technologies to perform cardiac surgery in children and babies, that dramatically changed the natural history of how these congenital heart patients do. As a result, the congenital heart population is getting bigger and bigger and bigger because we have many, many more adults who are making it to adult life, doing well and thriving. So what does this mean? We currently have at least, and this is at a minimum, this was several years ago, 1.4 million adults and 1 million children in the United States with a significant congenital heart defect. That's a lot of people. And you'll notice that there are more adults now than there are children with congenital heart disease. You also see that over the decades, 1965, 1985, 2005, if we look at the proportion of children in the light blue, pediatrics, the proportion of adults in red, previously, before we had cardiac surgery, very few of those kids born with congenital heart disease made it to adult life. This pie was mostly blue with children. As our cardiac surgical techniques have improved, now more of the patients with congenital heart disease are adults than children. So what does this mean? This means that doctors who have trained in adult medicine really need to become very familiar and comfortable with congenital heart disease because it is an adult problem now. And the complications that develop later in life are very unique from the complications that can happen early in life in children. This is just a slide just where we looked at hospital admissions and cost. And if you look over the years, and this is a fairly short time span, 1998 to 2005, all you have to see is all of these bars are rising, meaning more congenital heart patients are being admitted, the cost of those admissions is increasing. And so what is our job? Our job is to identify when these complications later in life may develop and intervene or do something about them so that these patients don't get admitted to the hospital with complications related to their congenital heart defect if it's something that we can prevent. Interestingly, when you look at the comfort level of most doctors with congenital heart disease, it unfortunately is not high. This is a graphic looking at cardiology test scores. So how are we doing in training our fellows and our cardiologists in cardiac disease? And we administer this type of test every year to our training fellows. We all have to take board exams. And that exam is separated into different segments. I won't go through all of this, but coronary artery disease, heart failure, valvular disease, hypertension, high blood pressure. These are all different common aspects in cardiology that we see in the hospital commonly. It turns out congenital heart disease is the area that cardiologists do least well on these boards. So we have a growing population of more adult patients coming to us, yet we have a workforce of doctors who don't feel as comfortable with this area of cardiology as others. So what is critically important is that we educate ourselves. We are investing a tremendous amount of energy now in educating our doctors about congenital heart disease so that we are accurately picking up some of these complications early in the disease process and preventing hospital admissions and preventing complications later. So we have a lot of work to do. So the other hat that I wear, not only do I see congenital heart patients, but I direct our cardiovascular disease fellowship. So I look at the totality of all the things we're teaching our fellows as they're learning to be cardiologists. And nationally, we have all come together to say we need to do a better job to teach our cardiology fellows about congenital heart disease. And as a result of that, many of the larger academic programs like Mass General and other institutions have really focused their energy on increasing the education for congenital heart disease because this population is rising so rapidly. This is slide is a little confusing at first, but I will go through it. So this is a slide, a very important paper that looked at referrals of patients coming to congenital heart centers over the years. So we have our years on this axis, 1990 to 2005. We had a set of guidelines when we realized that this population is growing rapidly. We developed a set of guidelines that said, you know what, when you identify congenital heart patients, we need to find a way to get them to a specialized center to get specialized care. Those guidelines came out in the late 1990s, and here we have the proportion of patients that are getting referred to a specialized center. So after those guidelines came out, we realized that this is really a critically important need in cardiology. Fortunately, there was an increase and a rise in the number of patients who are getting to congenital heart disease specialists. So that's wonderful. The other wonderful thing we saw is if we look at deaths among congenital heart patients, shortly after we see a rise in the referrals to congenital heart centers in 2000, 2001, we saw a reduction or a decline in death among congenital heart patients. So what does this tell us? If we can get these patients to centers or to doctors who are specialized in congenital heart disease, they actually do better. And why is this? Even though I'm showing you that congenital heart disease is growing and expanding quickly, relative to all other forms of cardiology or cardiac disease, it still is more rare. So it may be that if one is seeing patients in the community and you're seeing a lot of cardiac patients, it still is that these patients come more rarely. So if we consolidate their care to centers where there's specific expertise, we know that they can do better. So we've spent a lot of time in our program working with cardiologists in the community all around Massachusetts, all around New England, really doing our best to educate people about when it's appropriate to ask a patient to either make a drive to Boston or for us to engage over an electronic type of visit so we can help with the management of those patients, hopefully pick up complications earlier, reduce hospital admissions, and we hope reduce death related to their congenital heart disease. So, as I mentioned, death among congenital heart patients decreases with referral to congenital centers. So where are these congenital centers? Well, we're not doing a bad job on the East Coast. There are a number of different centers who really see a high number of patients over the course of the year. Mass General is one of these little dots over here. You'll see that there are many areas in the United States where there is no congenital heart expertise in a center that really sees a high volume. So we have a lot of work to do. Not only do we need to educate our patients and our families and our doctors, but we also need to figure out ways that we can bring the resources of this expertise to places where they currently don't have congenital heart centers. So when we think about cardiology, most of us think about common heart problems, heart attacks, right? High blood pressure, high cholesterol, congestive heart failure. Well, interestingly, as people get older, all of these things can still occur, even if you're born with a congenital heart problem. So how do we take care of people when they've developed some of these other, what we call acquired heart problems, now superimposed on their congenital heart disease? Well, we certainly want to make sure we take care of everything we can to prevent these acquired problems, cholesterol development, coronary artery disease. So treating high blood pressure, counseling about smoking and quitting smoking, helping people exercise and really exercise as much as they can to help their heart in a safe way, controlling cholesterol, one of the most critical things we can do to prevent heart attack. Congenital heart patients still are susceptible to all of these things, like all of us, And so part of our job, not only in taking care of their congenital heart problem and the unique issues that come with that, but is also making sure we're doing everything to prevent the acquired cardiac problems like cholesterol development and heart attacks. All of these components will increase the risk for atherosclerotic cardiovascular disease, which is another term for cholesterol deposition in the heart. The other point that I just want to touch on very briefly, and I mentioned early on, is about pregnancy. So the wonderful thing about seeing these children who very well may not have made it out of childhood 40 years ago, now not only become adults and thrive and they're busy and they're active and they're healthy, is we get to participate in watching them be part of creating a family and having a healthy family. Interestingly, pregnancy is a very big stress test on the heart. Anybody been pregnant in the room? I've been pregnant 3 times. It's different every time. And it is a stress test in that when one is pregnant, there is a whole lot of extra fluid that your body creates that has to come through your heart to get to that baby. In order for all of that blood flow to get to that baby, we have to increase the heart rate, we have to increase that heart pump to squeeze out more of that red blood out the body so it gets to that baby. It's a little bit of a stress test, right? If you walk outside or walk up a hill, you can feel your heart beating faster, you can feel yourself getting a little short of breath, and all of those things can happen when one is pregnant. Now, if somebody is born with a congenital heart condition and their heart may not be entirely normal, you can imagine that pregnancy may actually be challenging, they may be more symptomatic, and importantly, there's a higher risk of maternal complications in women who are pregnant with congenital heart disease. For a variety of reasons, they can have congestive heart failure, they can have arrhythmias, they can have blood clotting problems, right? So this is all for mom. Right, so if somebody's born with a hole in the heart.
That was me.
Okay, well thank you for sharing that.
Welcome.
If somebody's born with a hole in the heart and they develop a blood clot during pregnancy, it's possible that blood clot can go in places that we don't want it to go to, like the brain, and cause a stroke. Right?
What causes them, what causes like a hole in the heart? Like you were born with it, or your mom didn't take care of you, or?
No, not your mom's fault in any way, thankfully.
I know that.
So it's something that you're born with, right? Something that you're born with that as the heart is developing, that area just doesn't develop normally and a hole is left there.
Yeah, I was preemie, so
that can happen more commonly in premature babies sometimes, yeah.
But one thing about the body I noticed, 99% tells you what's wrong. Like 99, 100%, the body tells you what's wrong.
Your body tells you what's wrong, right?
Yeah.
People, right.
Sometimes
your body is very smart. It's amazing. Yeah.
Sometimes people don't follow, don't listen to their body. But you guys, you can damage more than they do good because your body knows what's wrong. So you gotta
always listen to your body. Your body will tell you when things are going on. So complications for moms who have congenital heart disease are higher than for moms who do not have congenital heart disease. So you can imagine, sometimes I mentioned that sometimes people aren't diagnosed with congenital heart disease until later. So part of what we also do is help to educate our obstetricians about carefully listening to the heart, really identifying if there's any problem with what seems to be a normal pregnancy, that we screen and look for congenital heart disease if it hasn't yet been picked up. Interestingly, moms can have obstetric events, so problems during the pregnancy itself, like high blood pressure, a condition called preeclampsia. They can have problems with the uterus. And then importantly, moms with congenital heart disease have a higher rate of fetal problems. So the baby could have problems where they're not growing well, or the baby may have malformations, or sometimes we see the baby also has congenital heart disease. So for women with congenital heart disease, being followed carefully during a pregnancy is critically important so that we do reduce the risk of having a complication, not only for mom, but also for the baby with pregnancy. So a few things to take home. One, there are more and more people with congenital heart disease now than there were years ago. This population is thankfully growing as a result of tremendous advances in the technology, particularly with pediatric surgery, pediatric anesthesia, and with our better technologies to intervene on complications as they develop. There are knowledge gaps, right? We have a lot to do in educating our doctors and nurses about congenital heart disease because relative to other medical problems, congenital heart disease in adult patients is essentially a newer field over the past few decades. Patients with congenital heart disease certainly have better outcomes when there is a dedicated congenital heart disease cardiologist involved in their care. So identifying that appropriate timing of getting them to the right place is critical. Access to care is challenged in many parts of the country. If you remember that big diagram of the United States, there are many places where we really need congenital heart experts. And then importantly, congenital heart patients can develop acquired heart problems like coronary artery blockage, so we need to be just as vigilant, if not more, about cholesterol and high blood pressure and exercise and weight loss and eating healthy and all of those important things. And finally, we hope that all of our moms who go through pregnancy have a very happy, successful delivery, free of any cardiovascular complications, and a big part of our job as congenital specialists is helping women and their families through pregnancy. So I could spend a lot of time talking about many, many more things, but I'll leave it at that, and I'm very happy to take questions. So thanks again for having me today.
Do you have a website about this? Do you have a website?
So Mass General has a website for our congenital heart program where we actually have a number of the specific congenital heart conditions detailed, a little bit about each of them, so that would be one resource. And then the Heartfelt Dreams Foundation also has a website if you're interested in contributing to efforts to better our education and support of congenital heart patients.
Do you have information on that?
There is information evolving. Maybe I'll have Eric say a quick hello and wave here.
Well, Heartfelt Dreams Foundation, as Dr. DeFaria mentioned early in her presentation, was established to support children and families with congenital heart disease, as well as the medical professionals, the doctors and nurses who care for those patients. And we do have a website that provides some information in that regard, but we're early in the process, and we're happy to take on any questions or help out in any way that we can. And we have a wonderful collaboration with Dr. DeFaria and Mass General in that regard.
Yeah, I have a question. I went to a CPR course. Somebody has a pacemaker and a defibrillator thing in the heart.
Yeah.
Is that recently happened, or is that normal, or what?
Yeah, so the question is, pacemakers and defibrillators, maybe when do people get those and why might they need them? So pacemakers are devices that can be implanted into the heart, so there's a small little battery that goes underneath the skin and some wires that go directly into the heart, that if the heart rate starts to get too low, then it will pace the heart to ensure that there's an adequate heart rate. A defibrillator is another type of device that sometimes can be attached with the pacemaker, that if the device detects a very abnormal heart rhythm, like a very dangerous heart rhythm, it will shock the heart back into a normal rhythm.
Also, it's planted into the body.
It's implanted into the heart, and there are very different indications for those two things, but many of our congenital heart patients may have developed abnormalities of their electrical system and may need a pacemaker. We've had some patients who need it very, very early in life, in childhood, and we have some patients who may not need a pacemaker until a bit later in life. But that's part of what we evaluate and screen for when we see patients.
Do you have any information on that?
There's a great site here at Mass General about pacemakers for patients. We could certainly direct you to that if you need more information.
Wow, that's interesting.
Question in the back.
Yes, I just have a question. Can a woman that gets pregnant while having a congenital heart disease develop other health problems later on in life just because of the congenital heart disease and then adding the pregnancy over it? Meaning, can she develop high blood pressure, high cholesterol, diabetes, and all these other things after the pregnancy already happened, even though the pregnancy had no problems?
That's a fantastic question, so I'll just repeat it. So the question is, do women with congenital heart disease who have a pregnancy and maybe get through that pregnancy without problems, are they at higher risk for a problem later in life? That's a fantastic question, and if I knew the answer to that, someone will win a Nobel Prize the day we figure that out. But interestingly, when we follow women with congenital heart disease who've had pregnancies, we do see changes in their heart. we think that pregnancy, particularly if women have multiple pregnancies, could potentially accelerate some problems with the heart muscle over time. Some women with congenital heart disease can have a higher risk of high blood pressure during pregnancy, and even if the blood pressure normalizes after pregnancy, they are absolutely at higher risk for high blood pressure later in life. And importantly, along with that, they're at higher risk for blood pressure related complications like stroke and congestive heart failure. So, for women who have congenital heart disease and have heart pump problems, maybe their heart pump is very weak, or their heart pump is very dilated, or they've had high blood pressure issues, this is actually a conversation that we have with them, saying, we can manage and get you through this pregnancy. We keep a close eye on you, we'll make sure that you and your baby are healthy. But one thing that's very hard for us to predict is, will there be some problems with your heart that may develop a little earlier in your life because your heart has undergone the stress of having a pregnancy that maybe wouldn't have happened quite so early if we had not gone through a pregnancy. The vast majority of congenital heart problems, women will go through pregnancy, and if they're carefully managed, they should not be at higher risk for problems moving forward, especially if they stay in care and they have their blood pressure managed and so forth. But there are certainly women where there is that risk. It's not something that's very well studied, which is why I say somebody will win a Nobel Prize one day, because I can't say for sure, your risk of heart failure or a heart transplant is X number higher because you're having this pregnancy. We don't know that answer yet.
I have an additional kind of question to it. Can genetics give us more answers to this? And the reason why I'm asking is because my mother has congenital heart disease, and I'm the only child. She was afraid to have any other pregnancies. She had several health issues afterwards. Is it possible for the child to have a congenital heart disease just because based on genetics?
Yep.
Or it's not related?
So that's a great question, and it really depends on what the congenital heart problem is. So there are many, many different types of defects that we deal with. Some of them are very clearly inherited in families, and we know that based on the genetics, it may be that there's a 50% likelihood that their offspring or their children will have a congenital heart problem. The vast majority of congenital heart defects, it's not quite that simple, and the risk of having, or the likelihood of having a baby with congenital heart disease is far lower, but is higher than the average population. So we usually quote, for many women with congenital heart defects, we usually say for the average person, the risk is on the order of 1%, something like that. Whereas for a mother or a father with congenital heart disease, the risk of them having a baby with congenital heart disease is on the order of 6 to 8%. So still the vast majority of women with congenital heart disease will have babies without congenital heart disease, but that risk is higher than the average population. There are some exceptions where the genetics are such that it's as high as 50% or something like that, but that really depends on the type of problem.
Thank you.
Yep.
If somebody has high blood pressure, can they get heart disease later in life, or?
So high blood pressure absolutely is a very important risk factor for developing coronary artery disease and other blood vessel or vascular problems like strokes. So this is why I'm sure all of you, when you go to your primary doctor, one of the first things they do is check your blood pressure. Most people, if that blood pressure is elevated, they don't know it. We don't have symptoms related to it. But what we do know is that if blood pressure is elevated or high over time, it really strains the blood vessels. It strains the blood vessels in the brain, which is why strokes can happen. It strains the blood vessels in the heart, which is why heart attacks can happen. So treatment and management of blood pressure is critical to preventing acquired forms of heart problems like heart attacks, cholesterol buildup in the arteries, and so forth. There are some people with congenital heart disease who have a much higher risk of having high blood pressure. So for example, a condition called coarctation of the aorta, where there's a congenital narrowing of the aorta, that big blood vessel that goes out the body. Those people, even when they're fixed early in life, say they're a few days of life, they have that surgically fixed and that blockage is gone, they still have a significantly higher risk of high blood pressure in their lifetime. Much higher than if they were not born with that condition, and higher even though we fixed it. So blood pressure is something that we have to monitor and manage on everybody, whether you have congenital heart disease or not. It's really important.
I have a question.
Yeah.
If somebody had a hole in the heart and they fixed it when they get early, like late on the age, like 48, and then can they have heart problems too with it? Like if they want to can they have heart problems if they fix the hole and everything?
So great question. So sometimes the holes in the heart aren't fixed until later in life. That's not an uncommon scenario. For some people, even if we close the hole, there might be some things that still can occur even though the hole is closed. Sometimes rhythm problems can develop where the heart may start to beat fast, or sometimes even the heart may start to beat slow. And that's part of the congenital heart defect. Even though we fixed it, there's still those residual things that can develop over time. Yeah. Sometimes we see if we repair holes in the heart later in life that even though that the heart size was big before we closed it, even though if it gets a little smaller, it may not get normal. So those people still may have a risk of having some congestive heart failure or problems with their heart pump moving forward. So absolutely, certainly need follow-up over time.
Yeah.
Hand in the back, maybe I'll just quickly get to the.
Hi. Yeah. Are babies born to mothers with congenital heart defects at a greater predisposition for other birth defects like prematurity, not necessarily related to the heart, developmental delays?
Yeah, that's a great question. So you can imagine that if mom's heart is having a hard time getting all that blood to the baby, it might impact how the baby develops. So on that last slide, you talked about fetal growth restriction, meaning babies are small, or fetal malformations. That can sometimes happen if the baby either hasn't gotten a sufficient amount of blood during the pregnancy or the mom's heart. There are many other reasons for that as well, but absolutely. And sometimes when that occurs, babies are born prematurely. So we see premature birth or preterm birth more common among women, particularly with more complex variants of congenital heart disease. So more simple variants, like simple holes in the heart or things like that, we don't tend to see as much in the way of fetal problems. But if the congenital heart defect is more complicated, we may see more. Yep.
Yeah, at that point, a mother is pregnant. Is there any testing that basically is done or being done right now to determine if in fact that, obviously the premature, not even premature, but the fetus, has a heart and it's beating, and how they do the ultrasound. Is there any other diagnostic test being developed to determine, obviously prenatally, before the baby's even born, if in fact there could be a cardiac issue?
Yeah, that's a great question. So interestingly, fetal ultrasound, just putting an ultrasound probe on mom's belly, that technology has evolved to the point where we can see almost everything about that fetus's heart. It's only a couple millimeters big. But with the ultrasound probe, we can see all 4 of the chambers, we can see all of the valves, we can see the outflow to the heart, meaning that pulmonary artery and that aorta that brings the blue and the red blood. There are very few things that we don't see very well with fetal ultrasound. Sometimes holes in the heart can be very hard to see on that small heart. But the vast majority of congenital heart defects are picked up on that prenatal ultrasound. All moms now receive that general review of the baby's organs. They look at the kidneys, they look at the brain, they look generally at the heart. For a mom with congenital heart disease, we do a special focused fetal echocardiogram, which is an ultrasound of the heart for the baby. And with that fetal echocardiogram, we can pick up all kinds of things. And we can make that diagnosis of congenital heart disease prenatally. And in some rare situations, there are congenital heart defects that may be amenable to an intervention while the baby's still in the mom's uterus, which is amazing.
Wow.
Amazing. So that technology is evolving. It's a very rare situation where that's feasible and that's an option. But the great thing about being able to make a diagnosis of congenital heart disease prenatally is that we can plan for that delivery and plan for that post-delivery period, get that baby to a neonatal surgeon very soon if we know that they have a congenital heart defect that's going to require early
Wow.
surgery and get those babies fixed early. And this is why you see the outcomes for congenital heart patients have dramatically improved, because our ability to make that diagnosis, to get those interventions done sooner, really changes the trajectory of how those kids will do. Fetal ultrasound is not perfect. There are a few things we can miss, but the vast majority picks up the vast majority of congenital heart defects.
Are you finding there's a genetic sequence in terms of, obviously in terms of family, for example, as you become, obviously so superior now in early detection, could there have been, great fathers, mothers, grandfathers, and so forth? Is any type of a genetic possibility that they can determine?
Yeah, that's a great question. So
they probably haven't gotten to that.
well, so the genetics of how a lot of the congenital heart defects develop, right now is not well known.
Right.
There are many centers who are trying to collect blood samples from people with congenital heart disease to evaluate their genes and evaluate their genetics. We are doing that here. And we have a research endeavor called the Cardiovascular Biorepository within our heart center here. And for patients with certain congenital heart defects and then also other types of heart defects that are not congenital, we will obtain a sample of blood. We will bring those together in a freezer and save them until we have enough to analyze. And then we can run the genetics on a population of patients whose hearts look similar. So for example, I have a few different types of congenital heart patients where I'm evaluating the genetics of their congenital heart defect. One example is a congenitally abnormal coronary arteries. So normally the coronary arteries develop, one's on the left side, one's on the right side. They supply blood flow to the two heart pumps. Sometimes people are born with coronary arteries that come off in the wrong location, and they're sort of doing the wrong job. And you can imagine that could cause problems early in their life. Sometimes we see they have heart attacks in childhood, they have arrhythmia problems. We know we, meaning the medical community at large, internationally, know absolutely nothing about the genetics of why coronary anomaly problems happen. We are fortunate that we have many patients who've come to Mass General over the decades with this particular problem, and we've been slowly collecting some of the blood from those patients, bringing them together, and we hope to be able to evaluate the genetics for that. So it's problem specific. The genetics are likely highly complicated and variable, but I think in time we'll have a better understanding of what some of those genetics are that predispose people to having a congenital heart defect. It will take time, but we will get there.
I have a question.
Yep.
Excuse me, do you think, like he said about generation, the generation like in the 1800s, in your family, do you think they had the heart problem too back then, or?
In the
1800s, do you think that?
There was lots of congenital heart. They would often diagnose it on an autopsy, unfortunately. All of our studies from the 1800s, it's often the first diagnosis of congenital heart problems, and most of them are autopsy reports after patients passed away. They would look at the hearts and they would make the diagnosis. We didn't have ultrasound then, or catheterizations, or things that we have now to pick up the diagnosis. Amy has one.
Yes, I have a question from the audience. What surgeries are needed as an adult for CHD?
Great. So it really depends on what the congenital heart problem is. So for example, I mentioned tetralogy of Fallot, where there are 4 problems that are fixed in childhood. The most common complication later in life is a leaky pulmonic valve, and that's something that we screen patients for over time. And we have guidelines now that help us identify when is exactly the right time to fix that pulmonic valve. We don't want to fix it too early in somebody's life and sort of expose them to the risks of a surgery that they might not need. But we also don't want to wait too long and fix the valve after the valve leak has caused lots of problems with the heart pump. Then maybe at that point we fix the valve and it's kind of too late. So for that particular problem, we sort of have guidelines about what the appropriate timing is for intervention. That's a very common surgery. There are some patients who are born with very complex kinds of congenital heart problems, like maybe one ventricle, one big open ventricle rather than 2 separate heart pumps. Those patients tend to get several surgeries in childhood, maybe 3 surgeries in their childhood. And then as they become adults, they may either need to be considered for another big open heart surgery in their 20s, 30s, or we need to perform a transplant. So thinking about heart transplant versus another corrective surgery as part of our job, we look at the whole ultrasounds and all of the information we have and we say, would it be best that we fix this one valve or two valves, or is this heart generally not doing very well? We need to just put a brand new one in there. And we have many of our patients that have gone through heart transplants here and done very well. So if you identify the right patient, that may be their best surgery as an adult. Whereas some other patients, a valve replacement or opening of a blockage or some kind of graft may be the right surgery that they need in adulthood. Everybody's different. The other fun, wonderful thing about congenital heart disease is every patient is very different and very unique, and so you can't always just say, well, we did this for this person, that's the right thing for that person. You have to really tailor their treatment and their therapy and the timing of their surgeon for what's right for them.
I have a question.
Yep.
Secondhand smoking is bad for you, right?
Yes, secondhand smoking is very bad.
Yeah.
Very bad.
Tell the folks
Good
that.
point. Secondhand smoking is very bad. It is. Question back here.
I see a difference in how they treat the adult patients now. The older I'm getting, I'm one of the patients, and the older I'm getting, it's exercise, 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 black everywhere. We just walked up here from the commuter boat, so I had to catch my breath afterwards. But and I just see that they say, you know, just the diet, the you know, it could. I'm controlling the high blood pressure.
Yeah, you know what is so interesting, and thank you for coming and sharing that. You know what is so interesting is many years ago, when these children were just starting to make it into adulthood, nobody really knew how to manage them and what was the safest thing to advise them. So doctors years ago used to advise that people with congenital heart disease they should not exercise. You know what, don't do too much, don't stress your heart out. We don't know what will happen if you stress your heart out too much. Interestingly, as a result of that, we then realized we had an obesity epidemic in the congenital heart population. Patients were inactive. They had been told by their doctors not to exercise because maybe we didn't know, maybe it was dangerous. We have spent a lot of time studying exercise. What does exercise do to the heart? When is it dangerous? When is it helpful? We know that in people without congenital heart disease, people with heart attacks, people with strokes, people with high blood pressure, exercise is critically important. It makes the heart better. This is actually another area that we've been researching and looking at exercise function of the heart, looking at how people, particularly with tetralogy of Fallot, do with exercise. And interestingly, what we find is that patients who exercise regularly, meaning aerobic type of exercise, walking, biking, swimming, things that get your heart rate up, that strengthens the heart muscle over time. We used to worry that that kind of exercise might be dangerous. It would stress the heart out too much. We didn't want to cause a problem. In fact, it's exactly the opposite. Regular aerobic exercise strengthens that muscle, and when we evaluate people and we evaluate their hearts with exercise, we have a particular type of exercise test we do that's tailored for our congenital heart patients, where we look at their heart, we look at their lungs, we look at their overall exercise capacity, we look at how the ventricle's doing with exercise. We see the people who have exercise, taking care of themselves, their ventricles are able to do more with exercise. They've trained their ventricles to do more. So this point about exercise is not only important for anybody who has a cardiac condition like a heart attack or high blood pressure or congestive heart failure, but it is particularly important for people who are born with cardiac problems. That heart developed under some abnormal conditions. So from the get-go, early in life, that heart has had to do a little bit more, so we have to train that muscle. And you'll be really surprised, people who exercise and take care of themselves and walk regularly and exercise regularly, they're the people who come into our office, they hop up on the table, they're feeling good because they've conditioned their muscle. Now, there are some people that despite their best efforts, they're exercising. Some of the complications that can happen later, like leaky valves or blocked valves, that's not their fault. Those will happen anyway. But they've been able to sort of delay the progression of that really impacting their life and their quality of life quite a bit by exercising. So not to say things will never happen if you exercise. Of course, things can still evolve that are unrelated, but the exercise piece is so critically important. So keep up with your exercise.
To your point, I was diagnosed at 6 weeks old at Children's Hospital, and I'm 72 now. But my doctor that I was seeing regularly as a PCP at that time, said, don't have her do everything she can do. Do not have her just lying in bed.
Right.
Because at that point, they said she'd go home and put her in bed.
Yeah.
And they didn't do it. They followed the doctors. And
Yeah.
3 open heart surgeries and many
Wow.
things from Mass General afterwards, so I'm here.
Great,
I have a
that's
question.
wonderful, that's
So-
wonderful.
I have another question. When I was growing up, my lips were turning blue. I didn't know at the time at the hole. You remember Referrals, miss?
Oh, yes, yeah.
Yeah, and my lips were turning blue. Then, when I was 46, I had my legs went under me, and I found it when I had the hole in the heart. You think the doctor would know better if my lips were turning blue or but?
So when the lips turn blue, that can
Yeah.
happen for a number of different reasons.
Yeah.
So there are many different reasons, but that is something that can happen to people with holes in their heart. Particularly, sometimes it gets worse if they're, walking around. The lips may get more blue, and that's
Yeah.
something that needs to be evaluated anytime we see that. There's certain tests that we do to evaluate that.
But like I said, I didn't damage my heart enough. Did I damage my heart? My legs went on me, but did I have like a heart attack?
I don't know exactly your heart history. I can't comment. I don't
Okay.
know, but that would be something to ask your heart
I
doctor.
asked her. I do have a heart doctor.
Okay, good. That's great. That's great.
Yeah.
Are there any other questions or questions from the audience? Great. Thank you for such a lively discussion. This is great. So thank you so much. Thank you so much to Eric and Lori. It's such a privilege to be part of their lives, and I am just so grateful that they are supporting our educational efforts for congenital heart disease. So thank you.
Mass General's a good hospital.